All right. Thank you, everyone, for sticking out till the end, and thanks for the panelists for this opportunity, and congrats on a great conference, and congrats to the other presenters on some really nice cases. So I'm Dan Feldman. I just finished up my structural fellowship at the Minneapolis Heart Institute, and I'll be presenting a case from this past year. I don't have any disclosures. So this case involves a 73-year-old lady who was referred for worsening dyspnea. She had a history of bicuspid aortic valve, developed severe AS, for which she underwent a surgical AVR back in 2011. This was unfortunately complicated by patient prosthesis mismatch and eventually endocarditis and paravalvular leak, so she had to undergo a redo surgical AVR along with an annular enlargement back in 2017. She also has AFib and CKD. So jumping straight ahead to her diagnostic TEE, you can see here there appears to be two abnormal jets. One seems to be related to MR, and then the second coming from an unknown area, but looks like, around the insertion of that anterior mitral leaflet. So focusing on the mitral valve, she's got severe MR with a posteriorly directed jet, which appears to be kind of on the medial side of A2P2, probably related to a restricted posterior leaflet, which you can see here. And the other abnormal jet that we saw in the diagnostic shot turned out to be a LVOT left atrial fistula, demonstrated here, in which we confirmed on a CT scan, measured 10 by 6 millimeters. So we really wanted to spare her from a third sternotomy, and we felt that both lesions probably needed to be treated and would like to do it in one setting. So the plan we came up with was to attempt percutaneous closure of the fistula first, since it's a little bit less predictable, and if that's successful, go ahead and proceed with MitraClip. If not, you'd have to go to surgery for both lesions. So if you were at the complications course on Wednesday, Paul gave a real nice talk on intracardiac rails, and it's been our practice that in these cases we expect a complex closure that we up front plan to create a rail. So for this case, we require arterial and venous access. We wanted to try to attempt to cross from the LA into the LVOT. So to achieve this, we got 12 French dry seal in the femoral vein. I went up, did our transeptal through the dry seal, as though we were anticipating that we were going to be doing a MitraClip. Then we went up with a steerable sheath and a gillis, through which we advanced telescoping 5 French and 6 French catheters, and then through those, we sent up a long angled hydrophilic guide wire. And we tried to cross from the LA into the LVOT, but unfortunately, we tried for a while and we couldn't cross. So we decided to change our strategy and come from the LVOT side into the LA. So we took a JR4 across the valve and actually just kind of clocked it into the defect, almost like engaging an RCA. And once we engaged the defect, we were able to advance a wire into the left atrium. So the next step in creating a rail is snaring. Oftentimes, you snare the wire, but sometimes you can actually make life easier on yourself and actually try to snare the catheter. So the JR4 is going to be a lot more steerable and directable than the wire. So what we did is we followed the wire into the left atrium with the JR4. It went actually pretty easily. Then retracted the wire back into the catheter and actually snared the catheter itself with kind of a loose grasp. And then at that point, we re-advanced the wire out of the end of the catheter and then walked the catheter back over the wire so that the wire is in the snare, and then just cinch down and externalize our wire. And in doing so, we were able to create an arteriovenous rail. Several reasons why we like to do this up front. One is it provides excellent support for device delivery. It really can make your life a lot easier to try to deliver equipment. And two, you guarantee to maintain wire position throughout the whole procedure. So whether you're having multiple devices, whether you have to recapture, whether you have to change strategies and come from the other side, you've always got wire position. You don't actually have to rewire that lesion again. So this is us advancing the delivery sheath up through the aortic valve and actually into the aorta. We had to actually withdraw back below the aorta before we sent out the distal disc of our plug, because you don't want to have that hanging out when you drag across the aorta retrograde. So we elected to go with a 12 millimeter AVP2, which we just advanced alongside the rail through the delivery sheath. Here we're unsheathing that distal disc, and then pull back to the fistula and release the rest of the plug, which is shown here. So everything looked pretty good on echo. There's really only trace residual flow through the fistula. Our Tug Test, it looked very secure and stable. So the next step is actually, before you release the plug, is actually to remove your rail, because you don't want to potentially risk embolizing your plug after it's been detached from the cable. So first we take out the rail, and you want to pull from the side that you snared, just so that kinked side from where you snared doesn't potentially grab onto your disc and embolize it. And then after that, we're able to release. So our device looks nice and stable here, and on echo, there's really just limited residual flow through the fistula. So next, we turn our attention to the mitral valve. We just checked to make sure that we had a good height where we crossed and everything was acceptable for MitraClip, which it was. So we went and proceeded. We exchanged out the Agilus for the MitraClip guide catheter. We used an NTR clip, which we aligned over that medial jet. Went down, got a real nice grasp, and we had a nice reduction in MR, and everything looked great until we checked the gradient, and wound up being 10 at a heart rate of only 55. And this caught us a little bit off guard because the baseline really wasn't suggestive of any problems with causing mitral stenosis. So the question is, what do you do now? Really, leaving it's not an option with a gradient that's that high. She's not going to do well with that. I don't think there's really any option for repositioning and trying to see if your gradient changes. We're in the one place that the clip needs to be. We're using an NTR clip. The other option would be, do we have to admit the feet and send her to the OR, which would be kind of disappointing after all this work, or is there any other option? And it turns out there is one other trick you can try to do, and I don't think this is widely publicized or commonly done, but you can actually open your clip arms up to 30 degrees and still release your clip in an attempt to try to decrease your gradient. And when we did this, we actually dropped the gradient in half, down to 5. And remarkably, we didn't really give up any ground on our MR reductions. Things still look pretty nice with respect to that. So we were confident in our grasp, and we were happy with our results. So we released the clip, which is shown here, and looks stable in 2 different projections. It does look a little abnormal to see the clip arms open like that, a little unsettling, but in fact, it was actually quite stable, and we had a nice result. And this is just that same 4-chamber view showing both devices and reduction in any of that abnormal flow. And then just a 3D image of both devices as well. So I saw the patient in clinic at 1-month follow-up, and she was actually doing great. She said her dyspnea had significantly improved. On echo, she had no residual flow across the fistula and only mild residual MR. Transmitral gradient crept up a little bit to about 7 millimeters of mercury, which is entirely unexpected, and it's obviously suboptimal, but probably an acceptable result for her, and she was feeling really good. So in conclusion, when you're approaching a cardiac shunt, you always probably want to plan up front for which side you want to address it, but there's always an option to switch over to the other side, and that's both with respect to crossing the lesion with a wire and delivering your equipment to the lesion. It's often helpful to use intracardiac rail to facilitate your device delivery, and snaring is going to be a critical step in creation of that rail. And lastly, and probably most importantly, you can open a clip up to 90 degrees and still release it if you're confident with your grasp, and you need to reduce your diastolic gradient. So thank you very much.
Dan, you want to talk about the choice of plug, or what was chosen in terms of AVP2? Why not AVP4 or an ASO device?
Yeah, I mean, I think it's just kind of our go-to workhorse plug in these sorts of cases. And the 12 millimeter size being a nice size probably for what we measured. So I think it was just the appropriate plug for a fistula closer there.
Okay. Questions from the audience at all?